don't we get started? I'd like to welcome everyone to this actually third faith session of the day. We had Allison Matthews give a keynote and then a really inspiring discussion session a few hours ago. So this is the third, and I hope we'll live up to the high standards set by the first two. And we do appreciate the International Conference on Stigma for having a day like this with a focus on faith. Faith and stigma have been linked for a long time in both good and bad ways. And today we'll be focusing on some good ways. We'll be talking about the way the faith communities act on the ground. When they're dealing with stigma, what do they do? And it's based on a case study done in collaboration with the World Council of Churches and Emory University. So John, why don't you introduce yourself and then we'll get started.
Hi, everyone. My name is John Blevins. I'm on the faculty at the Rollins School of Public Health at Emory in Atlanta, where I direct a program there that's been around for about 30 years at the intersection of public health and religion called the Interfaith Health Program. I've been involved in a variety of HIV programs and initiatives throughout my professional career. My first position out of seminary in 1992 was as a chaplain to adults and children living with HIV and AIDS in Chicago. And then even before that, while in seminary and in college in the late 80s and early 90s, I volunteered for various AIDS service organizations. I've done a lot of work in the Atlanta public health system in clinical care, but in providing psychotherapeutic services and psychotherapy to people living with HIV, as well as HIV patient education, coordinating trainings around untreated mental illness and chaotic drug and alcohol use as cofactors for HIV infection or disease progression, and then completed doctoral studies at Emory in 2005 in theology and gender and sexuality studies, and began doing work in global HIV responses starting in 2006. So glad to be with you and to tell you about some of the work that Dave and I have carried out in partnership with the World Council of Churches with the support of the UNAIDS PEPFAR Faith Initiative. Welcome.
Thank you, John. My name is David Barstow. I'm a computer scientist by training, but about 15 years ago, I somehow felt a calling to become active in the faith response to HIV. Spent a lot of time back and forth between the US and Southern Africa, especially, working with local faith communities to help them address issues of stigma. And that's been my focus for almost the last 15 years or so. I got to know John, I don't know, 5 or 10 years ago sometime, John. It's been a long time.
Been a while.
And every time I saw him, I said, John, we need more data. Can we do this? And he kept saying, Dave, that really won't work. And I tried this for several years. And then about a year ago, I said, John, could we try this? And he said, that one might work.
It's not that it wouldn't work. It was too complicated.
All right. Well, in any case, it was really gratifying to be able to work with John on this project. It was an investigation, a case study of a number of congregations done in connection with the World Council of Churches to just find out what is it that they do and how successful has it been. So that will be the focus of our conversation, and I'm going to do my best here to share a screen. I hope you all can see this. This is our topic. The issues we're going to cover. We'll be presenting the case study and then some theoretical and theological perspectives, some key findings. And then we'll look at what we can say about what best practices might be for local faith communities. And a couple of points during the session, we'll open it up to general discussion. If you have questions that you want to ask, please put them into the Q&A window, and we'll try to pick up on those during the discussion periods. But we'd like to start by showing you a video that was produced based on the case study. So I really hope this works. I think I pushed all the right buttons. Stigma has been a major barrier to an effective response to HIV since the earliest days of the AIDS epidemic. Sadly, stigma is still a major barrier 40 years later. The Global AIDS Strategy adopted last year by the United Nations lists stigma reduction explicitly as one of its key targets. Ending HIV and AIDS as public health threats by 2030 can only be achieved if we dramatically reduce the stigma associated with HIV.
You find the issue of stigma is still a big problem.
Effectivement, aujourd'hui, il y a beaucoup de groupes marginalisés par rapport au VIH/SIDA.
There's still, to this day, fear and stigma, not so much within our church, but in the community at large, locally, regionally, nationwide.
Discriminación, estigma y rechazo, tanto familiar, cultural como religioso.
When I was raped, that is my last rape, gang rape, contracting HIV, I became like a disgrace to the church.
Et ces gens qui sont démunis, délaissés par leur famille.
I've realized is those who I felt they did not accept me at first is those who are on top of me.
When these people disclose, they become stigmatized and discriminated.
Local faith leaders and communities have a critical role to play in stigma reduction. Why? Because faith communities are everywhere and because their leaders are widely respected, not only by their members, but also within the wider community. This chart shows data about attendance at religious services in 9 African countries. All these numbers are in the 75 to 90% range. So collectively, faith communities impact very large proportions of the population in these and many other countries.
L'Église est finalement un centre d'accueil pour toute personne, surtout celui qui souffre.
I mean, we're all created equal in the sight of God, and that no one's beyond the bounds of God's love.
Our role as Christians is to lift each other's burdens.
We are the hands and feet of Jesus in the community.
Faith communities truly hold the key to ending the stigma.
Faith leaders and faith communities can have a huge influence. Sometimes that influence can be helpful, sometimes harmful. We all have heard stories about faith leaders and communities who reject people living with HIV and who condemn population groups that are at increased risk. But today, we are going to share stories about local congregations who have been helpful, who have deliberately decided to reduce stigma and to support people living with HIV. We hope that these stories will inspire other faith communities to play their part in ending stigma, ending inequalities, and ending AIDS.
They showed me love by supporting me in every situation I faced.
Jésus est venu pour les malades.
The love of God is towards all of us.
They feel it is not the end of the hope.
It's our red ribbons on the outside of our church, on our steeple.
La Pachamama es fundamental en sus vidas. Caminamos a la par.
I regained my self-esteem.
People engage when it hits home.
In the first half of 2022, Emory University in the United States and the World Council of Churches collaborated on a project to gain a deeper understanding of the role of local faith communities in addressing HIV-related stigma. We selected a number of congregations with stigma reduction programs from around the world, from a variety of Christian traditions and geographic and cultural contexts that were quite diverse. We then went on and conducted semi-structured interviews with members of 7 of those congregations, including clergy and lay leaders, as well as members of the congregations themselves. In all of the congregations, the impact on people living with HIV was positive and helpful, primarily for members affected by HIV, but in some cases, also for members of the wider community, especially for those in the community who aren't members but are living with HIV or who are at risk for infection.
So the first support is prayer. And the second support is making sure that after prayer we take action.
Sí, son los primeros pasos. Caminamos a la par. Después caminan sola y lo hacen muy bien.
I am the pastor's wife. From there, I found it important for me to know my status so that I could be able to encourage other people to know their status.
I'm very positive about those marginalized groups, those who are living with HIV.
Donc, à travers ces actions d'accompagnement efficaces par des pères éducateurs, ils sont consolés.
A Jewish man living with HIV, and he said, you're not my faith, but you need to know how much those red ribbons have meant to me because they give me hope every time I round the corner.
It was also clear that effective stigma reduction can be a long journey. Most congregations started their initiatives many years ago, often triggered by a specific event or circumstances, and their commitment to providing care and hospitality and to model God's love to people living with HIV has resulted in ongoing efforts to broaden those efforts and to learn new ways to expand hospitality.
We called it the Funeral of the Month Club because we literally were going to a funeral every month.
That we are dying now, we need to find solutions now.
Auparavant, on était à la phase de sensibilisation, de la formation. Maintenant, on a dépassé ces étapes pour rentrer maintenant et dans la phase du traitement et d'autres formations.
The Bible contextual study, that's where we started. And we tried to transform the texts out of the Bible to our normal life.
These committees formed support groups.
We have a holistic approach whereby we try to support them spiritually, but also physically and emotionally.
Nuestro trabajo se realiza con mayor énfasis luego de la pandemia con compañeras trans, adultas mayores, indígenas.
HIV doesn't discriminate. When it comes, it comes. No matter you're a Christian, you're a Muslim.
Contextual factors, including the local culture and religious traditions, have a significant effect on congregation stigma reduction journey, especially with respect to marginalized populations. And all of our congregations interviewed described their ongoing efforts to try and address their own biases and discomforts, working with different communities on the margins.
It wasn't enough for the church to lock itself inside the church walls, but to go out to people as Jesus was doing.
A young man came up to me, gay man, I don't know if he was HIV positive or not, but he said to me, I never thought I'd see a woman in the pulpit, and I never thought any pastor would ever preach about HIV.
We have the program of the Youth HIV, where youth come, they discuss how they can protect themselves.
So we went and visited the sex workers. We created that safe space to talk with them one-on-one. Those who are in my congregation, actually I would say I've never met a situation where people have this.
Something needs to be done to protect our women.
My congregation, about the drug dealers and the prisoners, the congregation do welcome. But the sex workers, the homosexual, that one say no. Say no. I don't know why, but it's say no.
It is mothers who are trying to reach those marginalized groups and showing us how, as a church, we can go into that area.
Nous avons géré ces confrontations, ces discriminations en faisant des sensibilisations, en faisant des formations.
Despite these challenges, the congregations continue to persevere, driven by an abiding conviction that we are all valued children of God and are created in the image of God, and that this theological truth includes people who have been rejected by the society.
Everyone needs to take the issue of HIV serious.
Focusing on acceptance of all and decreasing stigma, it's an ongoing issue, and the only way for us to do that is to do it every day.
Nuestra iglesia va a estar a favor de las personas más excluidas y rechazadas.
We should continue the HIV program, expand to other communities so that we can continue to be the hands and feet of Jesus.
Par rapport aux autres congrégations, nous lançons vraiment un appel vif pour que les gens soient détournés de cette mentalité que le VIH-Sida est une maladie, c'est une punition de Dieu.
Less blame, more support.
We are all created in the image of God and we are loved by God, all of us, despite who we are and how we are.
I can't put myself in your shoes, but you can't put yourself in my shoes. So at some place, we just have to come to this common ground that there's a commonality there and we need to move ahead so it doesn't happen to either of us ever again.
Is it Matthew 25? When Jesus was telling a story that I was sick, you visited me, I was hungry, you fed me, I was a prisoner, you came to see me, and the other group was saying, when did we see you? What you did, the least people, you did it to me.
Hello, my name is Gracia. I am from Bolivia. I am a social anthropologist by training. I work in the World Council of Churches, leading the ecumenical HIV and AIDS initiatives and advocacy. We just saw a collection of stories of congregations responding to HIV stigma and discrimination. My question to you is, what are we going to do with that information? Are we going to be part of the healing hands of God that bring compassion and hope for people with HIV and affected communities, or are we going to remain part of the institutions that continue to perpetuate HIV stigma and discrimination? Myself, I'm living with HIV 22 years. All over these years, I have seen many people with HIV who passed away. Some of them died very young. Some of them died in complete isolation. And most of them died with the conviction that nobody loved them because they were facing rejection, even from their own families. And I kept asking myself, and now I ask you, why is it so difficult to fix our hearts and our minds when science is moving so fast? I am sure, as part of the Christian community, what God wants us to do is to become part of His healing hands and to bring hope, compassion, joy, justice, holistic healing, love, mercy, forgiveness for people living with HIV and affected communities. That is why we brought these stories together. And you can replicate the examples of these congregations. You can start by breaking the silence. You can educate your congregation with correct medical information and comprehensive prevention methods. You can provide holistic services for people living with HIV and reach out to the marginalized and vulnerable communities. And you can advocate publicly and strongly for equitable health care. And in everything you do it with us, with communities of people living with HIV and affected communities. I invite you to become part of the healing hands of our loving God.
Brothers and sisters, it has been a wonderful time together. We've heard from the panelists, we've been blessed by Gracia, our coordinator, and now you stand up and we receive the blessing. The peace of God that passes all human understanding, keep our minds and hearts in the knowledge of God and His Son, Jesus Christ. The blessings of God the Father, Son, and Holy Spirit keep with you, remain with you, encourage you, give you hope, give you love, give you victory, now and forevermore.
Amen.
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 Bind us together,
Lord, bind us together with cords that cannot be broken. Bind us together, Lord, bind us together, Lord, bind us together with love.
So John, go ahead, you take it away.
Thanks, Dave. So even though Canon Gideon just gave a benediction and a closing hymn, don't leave yet. We've got some more to talk to you about. Thanks to Dave for putting that video together. That represented a tremendous amount of work, and Dave has done all of that, and we are very appreciative. I wanted to just briefly walk through on this one slide the summary findings that were laid out in the video, just so you can see them all on one page. There were a number of programs and ways that congregations offered support to people living with HIV in the case studies that we carried out. Their efforts and their programs addressed spiritual and emotional needs. They also addressed immediate material and physical needs. The congregations represented that in order to provide care to people living with HIV and to work alongside and to walk alongside people living with HIV, their response had to be holistic. And they described a number of ways in which they did that. In all of the congregations, there were some people who were living with HIV, and in some congregations, there was an acknowledgement that the choice to be open about one's HIV status carried an inherent risk. And some participants that we interviewed described the ways in which being open about their status, even in congregations that had HIV programs and ministries, led to some sense of discomfort or isolation for them. Members of the congregation who worked on HIV programs were able to describe both the benefits of their programs for the congregation, for themselves, and for people living with HIV, as well as consequences. But all of the congregations and all of the people that we interviewed in the congregations identified that the benefits far outweighed the consequences. One of the most significant benefits theologically was the way in which participants described that their understanding of Scripture and the core foundations of their own theologies that they lived out in their faith and maybe articulated formally, but understood as driving their response to HIV shifted because of these programs. Participants described a much more open and holistic faith and an effort to try and embody God's love in concrete ways in a variety of circumstances and responses. One of the most interesting findings, one that we'll talk about a bit more in a moment, is a rich description of the context for stigma and an understanding that stigma is context specific and it occurs in a variety of ways and places. And a congregation's efforts to try and gain capacity to address one expression of stigma in their local community and in their local cultural context did not equip that congregation or any of our congregations to address all expressions of stigma. Congregations had different kinds of capacities and comforts in regard to these issues, as well as different kind of learning edges. Some of the congregations, particularly congregations in Eastern Africa, identified the ongoing challenges they face in addressing stigma in relation to men who have sex with men and in relation to transgender people. The stigma that surrounds LGBTQIA communities and people in Uganda creates challenges for a congregation that is working very hard to be open and inclusive to all of God's children and is still figuring out in their own lives and in their own ministries exactly what that means in the fullness of its expressions. Conversely, congregations in North America and South America describe challenges in addressing programs and services to people who use or inject drugs and some level of discomfort in regard to injection drug use and people who use drugs. All of the congregations identified the ways in which their anti-stigma efforts and HIV programs and ministries reflected their broader commitments to social justice, but they all also recognized that there were elements of prejudices and biases that they were aware of in regard to race and gender and sexuality. And they also acknowledged that there were unexamined and unconscious elements of that continued to manifest themselves in their congregation, even in the face of their anti-stigma efforts and HIV programs and ministries. But what was clear in all of the congregations in their description is that their anti-stigma efforts are a step in an ongoing process, and that an initial step toward opening their doors to try their best to reflect God's love by being a place of welcome and hospitality for some group of people living with HIV and AIDS created a change in heart and a change in attitude that led to successive and progressive efforts to open those doors further and further. Members of the congregations that we studied described the contributions of denominations and ecumenical programs that could help in their work, and also gave suggestions for other congregations that might want to start HIV programs and ministries. These are the 4 conclusions that came from the case study. These congregations have developed robust and innovative and thoughtful ministries that are varied in their expression, both for members of their congregations who are living with or affected by HIV and for the broader community, including those who are not members. These ministries are changing members' theological and biblical understandings. Their faith, in short, has been changed because of their effort to address stigma and to reflect and live out hospitality and welcome. There are still struggles and controversies as congregations wrestle with what it means to offer that welcome and hospitality, and that work is not done yet, and congregations don't imagine it that will ever be done. Cultural differences mean that those struggles are context specific in a variety of ways. I want to dig down a little bit deeper into this question and to reflect on these elements in relation to some theoretical perspectives about stigma. One of the things that we are working to develop in the broader global HIV response around anti-stigma efforts is more robust conceptual frameworks as to what stigma is, how it's generated, and how we respond to it. Our current conceptual understandings help us to think about stigma in regard to its primary function as an action that occurs through social networks to reproduce and to reinforce social differences among groups and across groups from one to another. And these reinforcement and reproduction of social differences are carried out so as to reaffirm the social identity and the social networks of those actors who engage in stigmatizing practices, attitudes, and perspectives. In other words, stigma is a way for people who feel threatened in some way to shore up their sense of identity and social cohesion in face of what they perceive to be a threat. Because stigma functions not so much around cognition or evidence and knowledge alone, stigmatizing attitudes and practices can't be dismantled simply through education, simply by pointing them out. Rather, stigma in general feeds on reproducing existing inequalities and finding a framework for justifying those existing inequalities. And some of the HIV-specific challenges related to stigma occur because HIV related to stigma most often reproduces or exacerbates inequalities that are based on race, gender, and sexuality. And in global contexts, those social forces or those social contexts also become implicated in how we understand colonial and post-colonial powers and histories, and the idea of outsiders, often from the global north, often white, telling societies, communities, congregations what they must do, how they must be in relation to differences in their own communities. Those kind of broader social scientific perspectives in regard to stigma are also reflected in various theological perspectives. The theologian and social ethicist Richard Niebuhr described inhumane practices as being grounded within social institutions themselves, because social networks beyond the individual have a capacity to remove us from seeing the other, the shared humanity when we meet another person who is not like us. They provide some sense of distance and isolation so that we can stigmatize and carry out violence toward another person. Individuals one-on-one tend to relate in ways that reflect kindness and shared humanity. There are ways in which Niebuhr's perspectives have influenced a lot of the theological understandings of stigma, and there is work coming out of liberation theology and Black and queer liberation theologies that challenge his idea that individuals always relate to one another with kindness and shared humanity when we meet individually, arguing that those kinds of humane practices that are grounded in broader social context reinforce a dehumanizing aspect that may be implicit or when we meet others who are not like us, and we're already preconditioned to carry out that kind of perspective when we meet an other who is different from us in regard to race, gender, sexuality, and other kinds of social differences. The British theologian Gillian Patterson, on work that she's done with the Ecumenical Advocacy Alliance of the World Council of Churches, has written some really interesting ideas on what she describes as the difference between the real code and the official code that happen in cultural context and societies. People will speak in formal ways about the codes of conduct that reflect the official code, what is agreed upon and identified as a socially acceptable kind of framework of norms and perspectives. But when they engage and interact with people who are like them, they switch to a real code, a set of perspectives and ideas and attitudes, a set of language that reflects a perspective far different from the official code alone. Theological responses to HIV-related stigma have to grapple with the real code that happens in the context outside of those places in which we speak and reinforce the official code alone. Doing that requires being honest about the reality of that real code and listening first and foremost to people who experience the negative effects of that code in their work and in their lives, and allowing them to take the lead on the insights and the revelations as to how we address it. Deciding to challenge stigma then, as I mentioned, is a process. It's not a singular step. It threatens our valued social networks and our standing in them. And so people feel a motivation to maintain stigma. Committing to anti-stigma efforts, however, set congregations on a path to ongoing discernment about broader and broader stigmatizing attitudes and to become more and more open, changing the congregation's actual understanding of themselves, the world around them, and the nature of God and God's love as they give up the perceived value that stigma offered them and instead open toward a perspective of mutuality and vulnerability. There are some insights that the academic consortium of the PEPFAR UNAIDS Faith Initiative has been carrying out for a number of years through some qualitative studies on religion and stigma in relation to key populations communities that relate to these kinds of efforts and insights. And I want just briefly to highlight some of the insights we're finding. In 2018, in collaboration and partnership with St. Paul's University in Limuru, Kenya, we conducted 154 key informant interviews or focus group discussions with members of key populations communities, including men who had sex with men, sex workers, and people who use or inject drugs. We were asking them about their experience or their attitudes toward accessing services in faith-based health facilities and faith-based organizations. And in the sub-Saharan African context around that region, the contributions of faith-based health facilities are essential to a comprehensive HIV response. In Kenya, for example, about 1/4 of all HIV treatment visits in which antiretrovirals are dispensed occur in a faith-based health facility and not in a government facility. And so those services are really essential to a comprehensive program and response to HIV. But members of key populations groups and other highly stigmatized groups are often reluctant to seek care in faith-based organizations because of active experiences of stigmatizing and judgmental attitudes that they've experienced in those facilities and in faith communities. At the same time, 140 of 142 people that were interviewed or participated in a focus group said that religion and religious expression remained an essential part of their life. that they were active in religious communities and participated in religious rituals and practices in organized ways in their own communities. And so people who felt most directly the effects of religion and marginalization were refashioning and negotiating for themselves a religious and spiritual life and creating religious and spiritual communities that often stood outside of the mainstream and often kind of reflected grassroots kinds of partnerships and collaborations and relationships being built and social networks being formed, often in response to the stigmatizing attitudes that they had felt and experienced before. And that reflects some of the insights from the case study that show the ways in which these congregations, by carrying out anti-stigma efforts, actually change the dynamics of their own understanding of their faith and their own social standing in the community. Congregations identified that they faced consequences by working to put aside stigmatizing attitudes, but they all identified that the benefits they received as they did so through the changes that occurred and their experience of being able to more fully understand in ways they couldn't before the nature of God's love, more than offset those consequences in terms of the benefits they received. But they were changed, and the social networks they were part of were changed by their anti-stigma efforts and programs.
So let's open it up to discussion. Let's see. The first question we have is: were there any specific denominations where individuals felt more stigmatized?
No, I mean, this was a very small study, so we wouldn't be able to generalize anything in relation to being able to say at a population level, this kind of denomination was more stigmatizing or less stigmatizing than this denomination. That kind of work might be done in subsequent iterations of this program as we interview more congregations and as we do a survey of congregational responses to HIV and their anti-stigma programs. But what we were looking to do in this particular study was to gain a richer, thicker description of the elements that influence stigma through a qualitative study. So it's a great question. It's just not one of the questions that we were asking in this study. What I can say is that we interviewed an independent congregation that was reflective of Roman Catholic teachings and traditions, United Methodist, a Methodist church in Togo, a Reformed church in Eswatini, Anglican churches in Kenya and Uganda. Dave, help me out here. A Presbyterian church in Malawi, Presbyterian church in South Africa.
And let's see, did you get the Methodist church in Hollywood?
Yeah, United Methodist Church in the United States. And so what we found was across those different denominations, individual congregations were committed to their anti-stigma programs.
And let me also add that even within any given denomination, you're going to find a broad range of things. There will be some congregations that work hard on stigma reduction, some that pay less attention to it. So it's really hard to make any kind of conclusions at all denomination-wide. We have a question from Sohail Rana. Did you visit any mosques or Muslim imams?
Great question. Again, not in this instance, Sahali. In this instance, because this was an initiative that was carried out with one of the implementing partners in the faith initiative, the World Council of Churches, it engaged only Christian congregations, different Protestant denominations, as well as one independent denomination in the Catholic tradition. But in this subsequent project here, we are expanding to carry out in 2023 and hope to carry out the same process with interviews of imams and lay people in local masjid, as well from the Muslim tradition, as well as from other religious traditions. That will depend on our implementing partners in the UNAIDS PEPFAR Faith Initiative, helping us to identify congregations and communities outside of the Christian tradition that we could conduct that work with. If you know of any imams or lay people working in your own context that we might reach out to, we'd certainly be interested in talking with you to get their names and possible contacts.
He responded, "I will be pleased to contribute to such effort." So we'll appreciate that.
Thank you very much.
Yeah, we really are hopeful to be able to carry this out in a broader way. We are pleased with the geographic distribution, but the cultural and religious distribution isn't as great as it needs to be. So we're looking forward to that. Thanks to all.
So Hal, I just put my email in responding to your last statement so that you can contact me.
Okay, I don't see any other questions.
I just wanted to respond to Michelle's statement there that she's not found much luck in the faith-based, and I'm assuming that might mean in faith-based organizations or in congregations. And I am sorry for that. As a person of faith myself, and also as a queer person, as someone who sought ordination in the Christian tradition as an out gay man and was not able to fulfill that vocational calling in my own life back in the 1980s and 90s, I am very aware of the ways in which faith communities can be incredibly stigmatizing in an essential part of people's identities and lives and experiences. And I hope that this kind of work will highlight and amplify efforts of faith communities to have a different kind of response, so that in your own life, Michelle, or in the lives of others who've had similar experiences to you, there will be local faith communities that are equipped to respond in different ways because they're learning the kind of violence and harm that has been inflicted through religion, and they are convicted to live out something different. So I'm sorry for your hurt and that lack of compassionate response. All I can do is say is I hope our faith communities will learn to do better and to be more faithful.
So thank you all for the questions and comments. One other aspect of this study was to identify specific practices that the various congregations did as part of their programs, and that merged well with a project that I reported on last year at this conference. And that was some recommended practices for local faith communities. So I'm here to give you an update on that. And just a reminder that the ways that local faith communities can affect HIV-related stigma, there are direct and indirect effects. They have a direct effect on members and families through support programs or prevention education. They can have a direct effect on marginalized populations by reaching out to those beyond the membership of their communities, but they can also have an indirect effect on societal stigma. That is, that the attitudes of their members change, then that has a broadening effect. And likewise, there is a community influence that leaders have that often goes beyond the bounds of their congregations. So last year, as I mentioned, we're putting together a list of what we hope will eventually become best practices. These are things that out of experience we've learned are the best things that local faith communities can do. And assuming we get to such a list, the role of this list of best practices would include guidance for local faith communities through training programs and online resources. It also provides a framework for measurement and evaluation. Namely, you track the adoption of these best practices, and you could even set regional or global targets. It also provides a convenient framework for research. If they are best practices, then presumably they're effective. So let's see if we can measure that effectiveness. And also, can we determine how widespread the adoption needs to be in order to have a broad social a broader effect on societal stigma. So we took the case studies that we did this year and kind of merged that with the analysis that I described last year on looking at a number of different HIV training programs. So we think we have a better list than we had last year, but they're not yet what we would call best practices. We think they're widely recommended, and we think they're close, but before saying they're definitely best practices, it requires more analysis and evidence. Just to remind you, these are the 8 sets of training materials that we used to make the initial list. Most of them were Christian oriented. There were a couple that were very specifically Muslim oriented, and also a few that might mention a little bit about other religious traditions besides Christian and Muslim. And just a reminder, this is where the congregation in our case study came from, that we basically compared the two to see if we could get some kind of unifying set. And here they are. First, talk openly about HIV and AIDS, consistently, repeatedly giving messages of compassion and hope rather than judgment and rejection. The phrase break the silence has been a very commonly used phrase in anti-stigma initiatives, and that's all this says. Talk about it. Second, motivate the HIV response by explicitly referring to sacred values and sacred texts. This was very common and reflects the fact that in many ways, the response is motivated by your faith and by your conviction about God's love and divine guidance. So let's refer to that love and guidance explicitly with sacred values and sacred texts. Third is provide accurate information about HIV and AIDS and correct myths and rumors that seem to spread all the time. This is basically just educate the congregation. And it's provide factual information and keep it straight. Fourth, always speak about HIV infection as a medical condition and not a punishment for immoral behavior. This is really important guidance because there is often a tendency to somehow associate what in your tradition might be considered immoral behavior with the effect of becoming HIV infected. The one way I've seen this done well was by Canon Gideon B. Mugisha from Uganda, who spoke about 2 different dimensions of human behavior. One is, I think he used the word legal behavior, meaning in accordance with God's laws and God's guidance. But the other is safe behavior, that is behavior that is safe based on what we understand about the science. And his point was that those are different dimensions. And so there are really 4 different kind of contexts in which you can talk about behavior. And this separation helps to focus the discussion, say we really have to make sure everybody understands what safe behavior means. Fifth, be careful to use non-judgmental and inclusive language. One of the challenges, and this is one that I think you could see in John's discussion of theological perspectives, and that's we have a tendency to think in terms of we and they. And in order to overcome stigma, we really have to get to inclusive language where it's all of us together. In fact, that was the motivation for naming the video, We Are One Body. We're not a we and a they, we're all one. 6, encourage all members to know their HIV status and if HIV positive to seek medical treatment. This is simple medical guidance. And just as we were talking about accurate information before, this is just saying this is what the science says you should do, and we encourage everybody to do it. And that's the way that we get to the targets that UNAIDS has set, 95, 95, 95, and so on. 7, develop a holistic accompaniment program for members living with HIV, including physical, psychological, social, and spiritual dimensions. That was one of the ones that came out most clearly in the study. The phrase accompaniment was used by a lot of the respondents, and the word holistic was used by a lot. And in fact, there is data to support the fact that, for example, data in faith-based clinics, when their treatment includes all four of these aspects, the HIV outcomes are far superior to what you would get without including those all four dimensions. 8, provide information and guidance about methods for preventing HIV transmission. This is one that is sometimes troubling for faith communities because they're worried that they're going to encourage behavior that somehow violates their traditional behavioral guidance. In the end, we talked with some of the training material developers, and the consensus was you really have to provide full and complete information. And generally speaking, just having the information, in fact, often leads to safer behavior rather than riskier behavior. 9, educate and empower young people to navigate life challenges. For many years, we've recognized the high risk of a youth bulge in HIV infections. Faith communities can be very instrumental in empowering their young people to get their way through this period of life in a way that is safe. Openly discuss HIV stigma and the ways that religion can both help and hurt. Sometimes these are uncomfortable conversations to have within a faith community, but they're also necessary. This is part of breaking the silence. Also, number 11, acknowledge and openly discuss topics related to HIV that may be challenging or controversial. For example, gender-based violence. These are, in many ways, can be the hardest conversations to have, but they're also some of the most important. One of the things that all the training materials said was just get the conversation started. Don't think you'll get an answer. You'll have one meeting and then you'll get it all figured out. Just start the conversation. Over time, you will learn how to deal with that. For example, in the case study, the pastor in Uganda who tasked with the Mothers Union says, okay, talk about this and figure out how we as a church can address some of the more challenging issues. 12, encourage interaction and discussion with people living with HIV and with marginalized populations in the wider community. This is really important. There's the principle that we've talked often about GPA, the greater involvement of people living with HIV and AIDS. When we put together holistic accompaniment programs, they need to be guided and in collaboration with people living with HIV. And this was, again, as you heard Gracia say in the video, work with us. And so this really is a very strong piece of guidance. But I'll also say that this is also different congregations have easier or harder times working with different marginalized populations. We saw that many times in the study. John talked about it earlier. So this kind of thing that we encourage in number 12 often takes a long time and may involve different kinds of interactions with different marginalized populations. Number 13, work closely with other community organizations to advocate for universal access to HIV prevention, testing, and treatment services for all who need them. All that's saying is that we can all be much stronger if we all work together. And finally, publicly proclaim the commitment to combat stigma and to welcome and affirm people living with HIV and marginalized populations. This is something that wasn't in last year's list, but it came out several times in the case study. You heard the discussions by Hollywood Methodists about the big red ribbon they had at the top of their steeple. You may have seen that picture. And that turned out, that just having that ribbon on the steeple turned out to be a major stigma reduction, have a major effect on reducing stigma and welcoming congregations. The example of the Jewish man who said he was given hope because he saw that everywhere. So this is a case, be strong and public in your advocacy. And be proud of the fact that you are combating stigma and that you welcome all of God's children. So this list of practices leads to, if assuming that we're getting close to having a list of best practices, that opens up some research questions. One is how widespread are the recommended practices now? In areas of HIV burden, how many religious communities implement which of the recommended practices? In areas of high burden, how many people participate in religious communities that implement the recommended practices? Those are two flip sides of the same question. And especially are some practices more widespread than others? That seems quite likely. Some of them are much easier to do than others. Some of them take a longer time. So we would expect that. What's the nature of that distribution? And then, of course, there's a question of how effective the practices are. Within a religious community, is there a correlation between implementation of the recommended practices and HIV outcomes for members? Within a religious community, is there a correlation between implementation and reduction of stigmatizing attitudes toward members living with HIV or toward marginalized and vulnerable populations at increased risk? And then this is especially important. In areas of high HIV burden, is there a correlation between widespread adoption of the recommended practices and reduction of societal stigma related to HIV? And of course, are some practices more effective, more important or more effective than others? As all of this kind of suggests, one of the things that we believe is that widespread adoption of such practices will have a significant effect, that we believe the answer to those research questions will turn out to be yes. First, though, we need to make sure that these recommended ones really are the best. So we need a wider consensus across faith traditions. We have tried to word them in ways that are independent of faith tradition, but we still need a broader consensus. And we need to develop evidence about effectiveness to make sure that they really work. In many cases, although these recommendations sound specific, they're also kind of general, and they need to be adaptive for specific contexts. Different faith traditions might adapt them differently, different cultures, different legal contexts, different marginalized populations. So there's a lot of development work to be done there. Training programs will be important, and I note here they're probably best if they're organized by national faith communities or even by national interfaith communities. And finally, I would just like to suggest as a sort of hypothetical target, depending on whether these really are close to best, that in areas of HIV burden, 50% of the population actively participate in faith communities that implement the recommended practices. This, to me, is a goal that we could say, all right, here's a global goal, let's work toward it, and tracking along the way. And 50% are kind of pulled out of a hat. I'll bet we need more than 10 or 20%. I don't think we need to get to 80 or 90. So let's aim for 50 and see how we do. So with that, let me stop sharing and open it up to discussion, questions.
If you have any questions for either me or Dave and Dave's description of the best practices findings, please enter them into the Q&A queue.
There's a comment from Sohail Rana. In the Quran, Prophet Muhammad, peace be unto him, is chastised 4 times by God. One of them was not paying attention or devaluing a blind person while the prophet preached to elites of Quraysh in Arabia. So that's the kind of reference to sacred values and sacred texts that is so important at the foundation of dealing with stigma.
Thank you for that reference. I also wonder if people have or would like to share any questions or comments about their own experiences or their own challenges or questions they have in relation to stigma and its effects in relation to religion and their work through congregations or faith communities and faith-based organizations. We don't have to only stick with the project and the case study that we carried out with the World Council of Churches. It's kind of hard to have a discussion when all we have is the Q&A box, but we'll do our best.
Yeah, in the meantime, Samuel Nixon had a question. Were there any notable differences of the female representatives in the extent to which they responded to the surveys versus the males? John?
They weren't surveys, they were qualitative interviews, and so they were in depth. But I would say, I mean, off the top of my head, I think we probably interviewed more women than men. And again, this is qualitative, so I wouldn't ever want to say we could generalize. What I can say is that both spoke at length and in depth around the questions that we asked them. All interviews ran, we developed interview guides anticipating that interviews would run 30 to 45 minutes. I don't think any lasted less than that, and some lasted well over an hour. And so we had really robust responses from both women and men. I didn't bring this up just because of time, but the big change we saw around the nature of the responses came from people in relation to their HIV status, either women or men. People who are living with HIV described more complex and more kind of ambivalent experiences with the faith communities that we conducted the study with than did people who were advocates for or wanted to walk alongside people living with HIV but weren't living with the virus themselves. Those living with HIV were far more attuned to and aware of the negative effects of unspoken bias, unspoken stigma that occurred, and were more honest about some experiences they had in these congregations and in the local community of ongoing stigma and bias that were still present. One of the things that I thought that this points to is Gillian Patterson's description of the real code versus the official code, that people living with HIV in unguarded moments with members of a congregation or of a community may experience and get a glimpse and feel that glimpse in a particular way of the real code that people will operate by, even if they don't talk about it, that some people will operate by, even if they don't talk about it. That was a consistent finding across the study, that people who were living with HIV described more ambivalence around the anti-stigma efforts.
Yeah, and that's actually interesting because one of the tools that's available for measuring stigma is something called the Stigma Index. It was developed by the global network of people living with HIV in conjunction with other parties. But part of it is that the survey takers are always people living with HIV. And so that may help the response to somehow be more reflective of the real code instead of the official code.
And not just in the survey, Dave, but also in if a country or a local community wants to conduct the stigma index and to go through the research process for conducting the study, any site-specific additional indicators or elements that they want to explore, there's a core set that they are asked to develop and to follow, but they can also develop context-specific ones, and those are also have to be developed in collaboration with people living with HIV.
Yeah, and that's part of an answer to a question from an anonymous attendee. Said there was a mention about societal stigma. How does that differ from stigma within the religious communities, or is there a difference? It's really just a difference in scale. The societal stigma is a phrase to refer to levels of stigma in the entire country or the entire city or the entire state or region. And the levels of stigma may be different among just, if you talk just about the members of a faith community. The levels of stigma might be higher, they might be less. And so that question about, or that target of 50% of the people worship at faith communities that have stigma reduction programs, that implement the best practices, that the thought there was that ought to be enough that because they talk with their neighbors and because their religious leaders might have conversations outside the congregation, that there would be a broader effect on stigma reduction in the society as a whole, not just limited to the members of the congregation. So I hope that helped address it. John, do you want to say any more?
I think one of the pernicious elements of religion motivating stigma is the power that stigmatizing attitudes and messages can have when they are backed up as being God ordained or God given. That if you believe that your faith tradition is telling you that the divine omnipotence deity that you worship is not only giving you a green light to stigmatize, but demanding that you do it, that's a tremendous force for generating and amplifying stigma. I can say that from a social scientific perspective. I can also say that from the perspective of my own faith, I see that power amplifying in really distinctive ways in Christian context and communities in my own life and in our HIV work. So I say that both from a social scientific and from a faith perspective.
Okay, we have several other questions. Michael Lee Orellano, in your study, did you find more women clergy to be more ready to engage to break the barriers in HIV stigma than men clergy?
Again, they're great questions around any kind of differences in the demographics related to gender, but the study's not going to answer any of them because this wasn't a random sample. So we couldn't say that these 7 congregations represent Christian congregations across the world as a whole. What we could say is that this was a purposive sample of congregations that we identified that were doing innovative anti-stigma work, and that both women and men, both clergy and laity in these congregations were able to speak about those efforts and what grounded them in rich and complex ways. As we carry out this study, and maybe if we get funding to be able to continue it over time, we may be able to say more about any kinds of differences around gender. But from 7 congregations, all of which were congregations that were chosen because they're doing anti-stigma work, we can't really say anything about either that question or the other one about the depth and range of insights being different for men or for women. What we have is a depth and range of insights, both by men and women whom we interviewed.
Samuel Nixon has another one. Were the concerns about the effect of society's response to HIV on the children and generational direction of growth within society, especially within the faith community, expressed during any of the interviews?
There were questions of the effects of stigma and on the congregation-specific HIV responses in relation to children came up both for children who are living with HIV and whose parents and whose mothers are also living with HIV, and the children who were infected perinatally, as well as children who were not infected whose parents are living with HIV, and the concerns of that generation who is living with HIV, possibly leaving orphans behind and also leaving senior adults who rely in many parts of the world through extended family networks, who rely on their adult children to care for them in their later years. That's a real kind of issue of the social cost. And that came up in congregations across the lifespan, both in relation to children living with or affected by HIV. It came up in ways about providing direct material support to those children. For example, helping to pay school fees and to purchase school uniforms, to make sure that they were welcomed in religious education programs and in children's ministries and programs within the congregation, and to address HIV in among adolescents and HIV adolescents in the congregations. I think that there are some real resources in faith communities on the pediatric response. UNICEF did a study a number of years ago that demonstrated that over 50% of the HIV initiatives, pediatric HIV initiatives in the world, have ties to faith-based communities. Now, that number may have changed as we've developed new funding structures for the global HIV response, but that study was really demonstrated quite clearly in my mind that the pediatric HIV response was built on and predicated upon the support of faith-based congregations. But even that, I think, is a complex issue. Faith-based organizations and faith communities have done some really tremendous work in the pediatric response. That doesn't mean they're equipped to work with those children as they mature into adolescence. Being able to address the needs of children living with HIV doesn't automatically mean that you're skilled to address negotiating sexual feelings, sexual practices, negotiating sexual debut, understanding how you protect yourself and make smart choices in regard to your sexuality and your sexual behaviors, and how you protect yourself from HIV infection or transmitting HIV infection if you're an adolescent living with HIV. And so some of those challenges related to adolescent HIV, our faith communities and faith-based organizations that are really skillful in pediatric program may not always have the similar kinds of skills in regard to adolescents.
But I'll point out that best practice number 9 is educate and empower young people to navigate life challenges, because that is a big concern.
We did this interesting, and this is published. I'll be happy to share if people wanted a citation for it. But we did a really interesting case study in Kenya on this very question. And the title of the manuscript is, "Are Faith-Based Organizations Assets or Hindrances to Adolescents Living with HIV? Question. They are both, period." So what it demonstrated is that some really important faith-based organizations that were pediatric programs were absolutely essential in providing essential life-saving services for children who are growing into adolescence in the informal settlements of Nairobi. But those same organizations were very limited in their capacity to help those children living with HIV negotiate their sexuality as they grew into adolescence. And there's no way around that. That's the effect of a whole set of social forces that are at play.
It seems like anytime you ask the question, has religion helped or hurt some aspect of HIV? The answer is always yes, both.
Yeah. And what's interesting to me, at least in the HIV space, is depending on the advocates, people only want to say one or the other. A lot of our faith partners want to say, "Oh, we do this great and we're essential partners." And I want to affirm their partnerships and celebrate their contributions. But I don't want to sugarcoat and to overlook the ways in which religion has also helped to drive some really horrific responses in the broader society in regard to HIV. Not so much through those partners, but religion more broadly. At the same time, there are a lot of people, particularly in the sexual and reproductive health space, who always advocate that religion gets in their way and makes their work inordinately more difficult. And I always say to them, here's what faith-based organizations are doing. If they weren't there, how would you fill those gaps? And they never are able to answer that, because those are essential gaps that have been filled by faith partners. And if they weren't there, adolescents would be dying. And so it is a complex double-edged sword.
Yeah. One more question from Sohail Rana. Have you published this data or prepared a manuscript? Please share how you structured your interviews.
So Sohail, we have a summary report that we shared at the Global Assembly of the World Council of Churches. We are turning that into a fuller report that we will co-publish with the World Council of Churches and the Interfaith Health Program at Emory in early 2023. I'd like to take aspects of that and pull in some more of the methodological elements to submit a manuscript for consideration for peer-reviewed publication. And that would come out in 2023 as well if it were accepted. Can't be the exact same report. One, we don't need to publish in two places, and two, peer-reviewed journals aren't going to just republish a program report. But I think there's enough there to do both, and we hope to do that in 2023. In regard to our interviews, we developed semi-structured interview guides based on qualitative research methods that allowed the interviewer a core set of questions and also provided probing prompts to go deeper in regard to those questions. And so no interview was exactly the same, but all of the interviews explored the same topics, allowing for some freedom for contextualization to explore elements that each interviewee brought up as they were interviewed. I'd be happy to let you see those interview guides if you would like to see them. You can email me and I can send them to you.
Yeah, and the interviews were structured slightly differently depending whether you were a clergy lay, whether you were living with HIV or not, whether you were a member of a congregation or not. So we got to the same general stuff from each one, but the questions were phrased sometimes a little differently.
And whether the congregation saw itself as conducting their HIV programs and ministries in an inward-facing way, as supporting members of the congregation living with HIV, or in an outward-facing way as providing those services to people in the community who were living with HIV or at risk for HIV infection, even if they weren't members.
Okay, here's one. Are you aware of any neurological studies that you know of about the brain on stigma, how it impacts brain wiring, perhaps?
It's a fascinating question, and no, I don't. And I'm laughing not at the question, but because of my utter lack of knowledge around neurology. It reminds me of a doctoral student whose dissertation I sat in on, and I was on our committee about 4 years ago at Emory, who did some qualitative ethnographic work with people who were in recovery from drug and alcohol abuse. And what she found is that the insights from neurology and taking those insights from neurological sciences into the clinical treatment of addiction was changing the ways people understood themselves in relation to the question of powerlessness in the context of addiction, and complicating how they related to narratives coming out of the 12-step tradition and programs. She explored that from a spiritual and religious perspective, but what she found is that insights about neurology and capacity to address addictive behaviors changed the ways in which people carried out practices that were kind of located in their body. I don't know if there would be similar elements related to stigma, but it'd be an interesting thing to study and to maybe see if there has been any of that work.
Yeah, and Sohail Rana said that there is some data with functional MRI with the stigma associated with lung cancer. So there is at least a bit of what I call real data.
Hey, qualitative data is real. It's just fuzzier.
Yeah. Yeah, and he expanded and said there are centers, I take it centers of the brain, that are related to empathy.
to the person who asked about the neurological study, you're welcome in my response. And just please know that I wasn't laughing at your question. I think it's a great question. It's just so far outside my scope of knowledge that all I could do was laugh to say, I don't know, that's great, but I'm not the one to answer it.
Okay, we got to thank you after that. I don't see any more questions. There's been a lot of interest in this case study through these questions, and I think John and I are both really encouraged at the interest that you've expressed. And as John said, we are hoping to carry this on through next year, and that will include online access to surveys and things to help get a broader set of data. So I guess one thing we can promise to do is to send out, whenever there's information about that, we'll get a mailing list from the International Conference on Stigma and send it out. And that'll give you guys a chance to participate. And
all of you can see my email in my response to Sohail. And so if you have questions or want to follow up and emailing me, although Dave will tell you I'm really bad at responding to emails. you might want to email Dave instead.
Yeah,
he's much better than I am.
I'll fill in an answer to a question here.
And I'm also going to put in that same thread the URL link to the video in case anyone's interested in being able to access that video. As well as a link that describes the work of the Faith Initiative of the UNAIDS PEPFAR initiative. This report's a couple of years old now. It was done in 2019, but it'll give you some sense of what the UNAIDS PEPFAR Faith Initiative, their work on a variety of areas, including existing work on HIV-related stigma.
It looks like I'm going to have to type my email address again. I'm not sure whether it made it or not.
I see it under the answered.
Okay, good. Okay.
Once you put in once you type an answer, it moves into a different tab.
Okay. Well, you're younger than I am, so you're more technically savvy.
That's a very low bar, Dave. A very low bar.
Anything else?
I just want to thank everybody for taking the time at the end of the day to come to this session and to engage with us. And thank you for your work in addressing and challenging and dismantling stigma and to offer empathy and compassion to people who experience it.
Yeah, so I would also like to thank everybody and I really enjoyed the interaction and it was very encouraging. And also again, thank the International Conference on Stigma for having this sort of focused time to deal with the faith response to stigma. You know, I'm one of those who says, look, we're not going to end HIV without ending stigma. We're not going to end stigma without strong active participation from the faith communities. So we got our work cut out for us. We appreciate your encouragement.
Thanks, everybody.
Okay, I guess we'll just sign off. But thanks again to everybody. It's been a great discussion.